The NILSt trial tried to address the success rate of discontinuation of nilotinib after at least 2 years of complete molecular response, or what we call PCR of more than 4.5 logs reduction. In this trial, the success rate of discontinuation is close to 60%, in this case 58.9%, and this once again has reproduced the same data that other trials are demonstrated in the last 5 years. The NILSt trials once again put in the study of treatment discontinuation is being reproduced what we already previously have seen in many other trials. Discontinuation after at least 2 years of MR 4.5, or what we call also complete molecular response, is something that may be feasible. In terms of how many patients really achieve or discontinue or successfully discontinue, I think once and again we see the same percentage even if we do after discontinuation, after first, second generation TKI or second generation TKI. And we are talking about these already numbers between 40 and 60% depending on the population that we study. What is very interesting that we thought that second generation TKIs maybe have higher rates of success, but what is very important to really point it out that although we see the same percentage of treatment failure discontinuation success, the pool of patients that can be discontinued is larger, or at least is double, when we compare frontline or first generation TKI with second generation TKI. The D-STOP trial is another Japanese trial that tried to address the discontinuation or the success of discontinuation on patients treated with dasatinib. The interesting aspect of this trial is also trying to address if any specific population of lymphocytes that, as you may know, this has been associated with some of the effects of dasatinib, has any relation with the success of discontinuations. Once again, and as we have seen in multiple previous trials with imatinib or with nilotinib, and very interestingly, we see a success rate of around 60% of the year. It's true also that most of the failures of the relapses, molecular relapses that have been seen in these and other trials happen in the first 6 months. In fact, most of the patients, almost 80% of the patients, will really relapse shortly after, but there is a small percentage of patients that may really have late relapses. Once again, the result of these trials confirm the possibility to discontinue patients, in this case with dasatinib, but very, very similar to the data that has been obtained on nilotinib as well with imatinib. The monitoring of patients after treatment cessation is quite important. In fact, it's fundamental to really guarantee the safety of our patients when we try these interventions. The guidelines, the NCCN guidelines, and other really trials that has been performed in France and other part of the world always recommend to really have a monthly PCR for the first 6 months to really intervene early. In this case, the reason of intervention will be the loss of MMR, or in this case, PCR of more than 0.1%. That will be the threshold in which we need to really start therapy with TKI, most of the time with the same TKI, and as we know, most of those patients will really recover the same response that they had before. After 6 months of monthly follow-up, we try to really extend this period of time to every 2 months. This is defined in between 6 or 12 months. And after this time that the patient is still successfully discontinued with the lack of relapse, we can really go to the 3 months, and of course later on we can start to space them. However, it's important to point it out that those patients should be followed even for longer period of times, because there is being described late relapses, and I think with a very easy test as the PCR, we should or we can avoid these late relapses.